Finally, we're going to jump away from women's health and go a little bit into men's health, and we're going to talk about testicular cancer. When you look at the picture, you can see what the cancer looks like as it affects the testicle. That's on the left side. And then on the right side is where the tumor can spread and metastasize to. So it likes to go to the lymph nodes, and then it also metastasizes to the lungs. The good thing about testicular cancer is it's a low incidence when compared to other cancers. It's not even in the top 10. We have about 8,500 new cases per year, and your risk is 1 out of 263 men, which means of 263 men who are less than 35, one of them may have testicular cancer. So the risk factor is your age. If you're between 20 and 30, maximum of 35, there's a risk. If there's a history of the undescended testicle or late descension of the testicle when the baby is born, then that increases the risk of having cancer. If there's a family history, that will increase the risk. If there's been a severe injury to the scrotum, just that kick where sometimes you get kneed, you're playing football, you're playing soccer, and somebody kicks and it's pretty traumatic, that injury to the scrotum can lead to a testicular tumor. Men who have a history of having mumps, and afterwards, as they recover, they notice that the testicle has gotten smaller because they actually had orchitis, then they have a risk factor of developing cancer. And it is most common in Caucasian males. So the signs and symptoms, they're subtle, but remember our population we're talking about. These are men in their 20s and early 30s. They don't like to share stuff about their genitalia with us, and men in general don't like to come to a healthcare provider. So it may start out with a small painless lump in the testicle. They may have a heaviness in the testicle and they're wondering, gee, what the heck is wrong? As it's gone on, they may start having breast tenderness or enlargement of the breast tissue. And then we get enlargement of the testicle and enlargement of the scrotal sac, and then there can be testicular pain. So they finally come in, share with us what they're feeling, and we're going to do an ultrasound. Because just enlargement of the scrotal sac, they may have a hydrocele. Simple fix. We just can send them to urology, they do surgery, and they drain, reconnect some of the drainage systems, and over and done with. But if they see the solid mass, we have another problem. So we send off serum tumor markers in the form of the AFP and the beta HCG because these are stromal tumors affecting the hormones. And then eventually we do a biopsy. The medical management includes removing the testicle, and that's called an orchiectomy. And they'll also do a node dissection of the retroperitoneal nodes because we want to stage the tumor and see if it's just localized or what is the metastatic potential. These gentlemen end up going through chemotherapy, and if the tumor is greater than 5 centimeters, now that's a pretty good sized tumor, but that just goes to show you that men are not forthcoming when they feel something unusual going on down there. They'll be worried about it, but they're not going to share it with us. But these men need to have radiation and chemotherapy. And you can see by this picture, that is a very large tumor. And what ended up happening is the tumor put so much pressure within the scrotal sac that it caused atrophy of the unaffected testicle. So this gentleman ended up losing both testicles. Now they will do reconstruction surgery, and we have little replacement testicles, and they will put that in the scrotal sac so that they look normal. So when you're caring for these patients in the post-op setting, most of the time this is done outpatient. So you need to do a lot of patient education as you're discharging them. Remember, they're under anesthesia. So we're better to start talking about post-op care before the patient has the surgery itself when they're wide awake. So they should anticipate having some blood in their urine that should go away within 2 to 3 days. They need to apply ice pack to the scrotum several times a day and remember the principles of ice therapy, that they never put ice directly on the skin. They may have burning with urination. That's normal, especially because there's blood in the urine. They should not have any form of sexual activity or do heavy lifting or vigorous exercise until they go in for that first post-op visit, which is within 7 to 10 days. They need to notify the physician if they have unusual swelling. I've had guys come in who had a scrotum that was about 20 centimeters large. And they didn't come in immediately when it happened either. And what they can do is wear a jock strap or a supportive brief form of underwear for 2 weeks so that the scrotum is not so dependent, and it decreases the swelling as well as the pain. They may need to have stool softeners and or fiber to keep their stools soft so that they're not bearing down to pass stools, because that pressure backflows and it can cause swelling and more pain in the scrotum. So complications. Well, when we take out the testicles, because they no longer have that hormone therapy, is they lose sexual desire. And so what we can do is treat them with injectable or topical testosterone. They may have impotence. They can have hot flashes similar to what women go through in menopause. And we can control this once again with medication. There's a weight gain potential of 10 to 15 pounds because they no longer have that testosterone. They can have mood swings and depression because we have actually, part of it's hormonal, but part of it is this is their manhood, and it's very difficult to deal with. The enlargement of the breast is because of the decrease in the testosterone levels, and they'll have some fatigue, and some of that fatigue may be related to depression. And then loss of sensation in the groin and the genitals because we have cut the nerves and it never quite goes back to the way it was. Depending on how aggressive that they needed to do the surgery will increase the risk of them having loss of sensation. And then they're going to have additional risk of having another cancer at another point in time in their life. So they need to be taught to go in on a regular basis and see their internist, who needs to be vigilant about looking for the signs and symptoms of other cancers. So a big thing we want to do, and this is where you're going to come in, is prevention. They don't like to talk about this, but we need to teach them that they have to do self-testicular exam. And so you may be offended by the talk on this little poster, but you know what? This is how guys talk. So pause the video and look through the step-by-step approach of what guys need to do and the frequency of doing self-testicular exam. So don't let cancer mess with the testes. That's your bottom line. So this ends the lecture on testicular cancer.